or as a subtitle to this is HTAi in the real world, and how we have tried to apply and what are the decisions that have gone into translating evidence into practice in Singapore. Singapore has a hybrid healthcare system where we have both the public and the private sector. In the hospital sector, 80% is provided by the public sector, but in the primary care sector, it is the opposite, with 80% provided by the private sector. But in terms of decision-making and translating evidence into practice, I thought I would start first with the enablers that we have put in place in terms of preparing the ground for HTAi, the evidence generated from HTAi, to be implemented. Firstly, it is to start with the end in mind. What do we hope to achieve each time we make a decision in healthcare? So in Singapore, we have defined this as what we call our triple aim: better health, better care, and better value. And the central goal is to live long, live well, and with peace of mind. I think all healthcare systems can identify with this, but I think this is useful for us that every time we make a decision, we are checking against it. What is the outcome that we want at the end of the decision-making process? Next, we need to have an implementation process, because if we have evidence, but we don't have the receptacle, or we don't have the container, or we don't have the processes in order to carry it out, then the evidence will just remain where it is, whether it is in a journal or in academia. But therefore, we need to have mechanisms to translate the evidence into guidelines, from guidelines into protocols, because guidelines just say what you should do, but protocol says when you should do it, where you should do it, and who should do it, and then goes on into the action and the impact. And there must be a feedback loop, because it is when evidence is practiced in the real world that we really see how applicable this evidence is. And this feedback loop goes into the evidence side, the guidelines, as well as protocol. And we need to align the incentives. And the one key incentive is actually the financing framework. How does it, whether it is an inhibitor or whether it is a promoter? So in terms of financing options, I think in Singapore we have a diversity of financial options, and we feel that this diversity creates a more robust system because it enables different kinds of a threshold in terms of decision making, and it allows us greater flexibility. For example, we have individual financing through what we call our 3M system: MediSave, a health savings account, which is a compulsory savings account for all those who are working. 6 to 8% of our salaries are parked into this account. We have MediShield, what we call our National Catastrophic Insurance Scheme. And we have MediFund, so that those who can't pay for their healthcare costs, the government will then step in to help them, so that no one is denied healthcare that they need. And we have also government expenditure, which is the government subsidies. So we may make a decision such that an item may not be subsidized by the government, but it can be used, it can be paid under the MediSave, or it can be paid under the insurance scheme. So this allows us flexibility, but the key point is affordability to the patient, affordability to the family, so that the out-of-pocket payment is manageable. So, and this also allows resilience. For example, when the government budget is affected, if the economy goes bad, taxes get affected, and the government, but we still have other means to ensure that the introduction of technology and the evaluation of technology is able to proceed. Then the next enabler that we need is a targeting mechanism to ensure that it is sustainable. And this is where we need a strong governance framework to ensure that the right technology is used for the right person at the right time and the right place. Because evidence is generated in a controlled environment. It could be a randomized controlled trial, it could be a study where the inclusion-exclusion criteria are clearly defined. But evidence is used in the real world. Clinicians do not always follow the indications that has been prescribed. Patients would ask for certain things which are beyond the indications. So we need to ensure that what the evidence says, there is a governance framework to ensure that it is implemented in the right way. So how have we tried to apply this within Singapore itself? First, looking at drugs, we ensure access to drugs through our subsidy scheme, And one of the schemes that we have is what we call a standard drugs list, which is modeled after the WHO Essential Drug List, and established in 1979. We identified this as clinically relevant and cost-effective drugs and basic therapies essential for the management of common diseases affecting the majority of patients. So this is where it is the working on the principle of the greatest good for the greatest number of people. And it's applicable to the public sector subsidized patients. We have list 1 and list 2. List 1 are the essential first line, list 2 are the more expensive. But the availability of drugs to the public is not linked to the SDL listing. This is just government subsidy. The drug registration process by our Health Sciences Authority, or our FDA equivalent in Singapore, is this independent decision. And once a drug is registered in Singapore, it can be prescribed by any medical practitioner. It is not dependent on the subsidies. So even those in the public sector hospital can prescribe what we call a non-standard drug, a drug that's not on the standard drug list. And therefore, healthcare providers are not limited to the SDL drugs. The evaluation process is that submissions come from public healthcare providers. It's evaluated by our Drug Advisory Committee with the technical assistance of our Pharmacoeconomics and Drug Utilization Unit. And we have a prioritization criteria looking at therapeutic gaps, the line of therapy, the disease prevalence, type of outcome, affordability of the drug to patients, as well as cost effectiveness. We have recently expanded the access to the drug. In 2010, we have introduced what we call our Medication Assistance Fund, which subsidizes up to 75% of selected expensive non-SDL drugs, for example, the cancer drugs. But for these drugs, we require them to meet 2 requirements. One is the financial requirement, 2 is the clinical requirement. The financial requirement is that patients are means tested, so that the subsidies are given to patients who need them. But secondly, it is also to ensure that the drugs go to patients who need them, but from the clinical indication. So there are a list of clinical indications, and there is a means test to ensure that both the financial requirement and the clinical requirement is met. And in 2011, we also further expanded it because we found that the SDL is for common and majority. Medication Assistance Fund 2010 is for the less common, more expensive, but still a substantial number of patients. But we also recognize that there are patients with less common diseases or complex conditions. They may not respond well to standard drugs, whether they're allergic to it or they're not responsive, but it's assessed by the clinician to be clinically necessary and appropriate for the treatment of the patients. So for those, we will not manage it at the national level, but we handle it at the hospital level. So at the individual institution, like in my hospital, we will have to set up our own mechanism to assess the need of the drug on a case-by-case basis. So a budget is given to the hospital, and then we have to decide, based on the budget, which patient actually requires it. So these are for patients with less common diseases, the more rare diseases, and for patients who also require a higher and more expensive drugs. So this is how we try to tier the system to ensure that there's flexibility in decision-making, as well as ensuring that the drug reaches the right person, but with the governance framework in place. And we also do economic evaluations. For example, we did 2 economic evaluations of vaccines, where we look at the cost effectiveness, looking at the cost per case prevented, cost per death prevented, cost per life year gain, and also did a cost utility analysis. And this was for the pneumococcal vaccination as well as the HPV vaccination. And our conclusions were that both these vaccinations are considered cost effective and can lead to substantial health gains. But instead of putting them into the government subsidy scheme, our decision was that this will be, the pneumococcal vaccine is added into a national childhood immunization, but the family, the parents, can claim from their MediSave, their health savings account. So it doesn't come from the government budget, but it comes from the health savings account. And in Singapore, to encourage procreation, because we are also facing a problem of not enough babies, we have in place what we call a baby bonus. So the funds that are put in the baby bonus, where you have the babies, can also be used for this kind of immunizations. So this is another mechanism. And for the HPV, it was also made MediSave claimable, not as part of subsidy, but we recognize that this is not mandatory because there are people who will come to different decisions whether to vaccinate their children or not based on religious or social beliefs. But we also recognize that this needs to be coupled with an education campaign highlighting the need for continued screening because the vaccine doesn't cover all serotypes. Okay, so that is about ensuring access. But the other aim of health technology assessment is also to ensure that we provide quality care every time that a patient comes to us. And we have introduced what we call in Singapore a chronic disease management program, where I shared earlier, we need to translate evidence to guidelines to protocols. So this is the protocols that we have created, standardized evidence-based protocols to avoid, delay, or reduce the development of complications. And this evidence base is derived from the relevant clinical practice guidelines, where we select them based on our disease management, priorities in disease management, public health impact, as well as the utility of the guidelines. So every year, there's a prioritization exercise where we ask professional bodies which are the guidelines that are most relevant. And here, for chronic disease management, we translate them even into protocols. And it was launched in 2006, starting with diabetes, and now it covers mental health conditions. And we also allowed the use of MediSafe for these conditions because we want to reduce the out-of-pocket component to encourage patients to come to be managed in the outpatient to reduce their need for costly inpatient cost. But participating doctors, there's an incentive for them because now the patients in our primary care sector, as you explained, it is on a fee-for-service basis. So each time you see the doctor, you pay a fee. But with the use of MediSafe, the out-of-pocket component of the patient's payment actually reduces significantly. And this encourages the patients to come forward. And for our general practitioners, it's a win-win for them because then more patients come to them. But to allow them to use MediSafe, we accredit them and require them to submit reports based on care processes and clinical outcomes, and we provide these reports back to the GP with the relevant national and regional comparisons to show, as the chart below shows, the HbA1c, how do they perform as a clinic, how do they perform compared to their neighbors, and how do they perform nationally. So as a feedback mechanism as to, I have missed 3 steps in the protocol, and I find that my HbA1c is not doing so well. So in the privacy of their own clinic, they can then review and see how can they improve their own care, the feedback mechanism. So the feedback need not be a hard stance of the government or the regulator coming down with a stick, but we believe that our doctors, based on their professional ethos and ethics, would want to improve themselves. And we feel that this is not only for a particular setting of care, but we want to extend this across the setting of care, what we call patient-centered quality care, from prevention all the way to palliation, moving from institutional or setting-based care to population-based care, moving from silo-based to a system-based care. So what we have worked on is developing what we call integrated care path for 5 key conditions: stroke, diabetes, acute heart syndrome, hip fracture, and chronic obstructive lung disease, with rehabilitation underpinning it. And what we did is we set up national work groups. So there's a national clinical team that charts out the care that patients should receive across the continuum of care, from prevention to end-of-life care, looking at the latest evidence. Okay? So because we believe that if the evidence is there, then it should be implemented across the board nationally. It cannot be that I go to hospital A, I receive a different standard of care. I go to hospital B, I receive a different standard of care. The standard of care needs to be the same across the spectrum in Singapore. But we also recognize that in terms of implementation, there can be local differences in implementation. In some cases, take the example of the elderly patient, the hip fracture. In some places, the care is provided by a geriatrician. In some places, which doesn't have a strong geriatrics department, it may be provided by the general medicine people. And in some cases, it may be provided by the orthopedic surgeons. So we allow this local variation, but in terms of the element of care that is provided, it has to be uniform, and it should be based on the recommendations of the national clinical teams, based on the clinical practice guidelines, and then translating it into the care protocol, that across the setting, what they should receive. For example, for stroke, what should patients receive at the preventive stage? What are the screening that they should receive? If they receive a stroke, then thrombolysis within certain amount of time, what is the rehabilitation that they need, and how to integrate them back into society. So systematic reviews, this is an example of what our HTAi unit did, is to look at the evidence then across the different settings. Because now we are not just comparing drug A with drug B, but we are comparing an intervention, let's say, at the preventive stage versus the acute stage, which is the one that gives us the biggest bang for the buck. And this will identify the key elements, and our instruction is comply with what is known. So if the evidence is strong, we comply with it. But where the evidence is still unclear, that's where we allow innovation. So this is not cookbook medicine, this is not prescriptive medicine, but it is about, if you know that this saves lives and is clear, then it is our obligation to comply with it. But if it's an area that's unclear, that's where clinical research comes in, and that's where innovation is possible. And that's where it also helps to set our agenda for the research in the country. So we look at mortality rates, functional outcomes, and this is then the value judgment comes in. So in conclusion, just like to say that translating evidence into practice has 3 key considerations. Firstly, we need to take into account the contextual factors. It's not only at the national level, but also at the institutional level. What is the receptacle? How receptive is the soil? And if it's not receptive, how can we make it more receptive for it? The culture and the history. It requires the alignment of the incentive system, such as the diversity or the financing options, because if you have only one financing option, then it is very difficult to be flexible in terms of the decision-making process. But it also needs to be coupled with appropriate governance as well as a feedback and engagement framework. And finally, requires a mixture of pragmatism and wisdom, because some things are statistically significant but not really clinically significant in the real world. And do we have to wait until the evidence is 100% clear sometimes before we move? For example, if we have a pandemic, there are certain things which we need to do based on the urgency. So I think at the end of the day, it is starting at the end in mind again. What are we trying to achieve with every decision that we are making? Better health, better care, and better value. And that is the cost effectiveness part of it. So thank you very much, and I'll take questions later.